Thank you everybody for joining us. My name is Steve Pardue. I'm a managing member here at Elevate Oral Care. We're very honored to have 4 industry experts with significant experience in managing fearful patients in oral health settings. Tonight, the panel includes Dr. Philip Weinstein, Professor Emeritus at the University of Washington. He's a funded NIH investigator whose research focuses on the management of fear in children and adults and the effectiveness of motivational interviewing approach. He's provided treatment for over 30 years to patients at the Seattle-based Dental Fears Clinic, which he co-founded. Dr. Weinstein has written over 175 papers and 4 books. Marilyn Rothen is a dental hygienist with a master's degree in oral biology. She's a clinical associate professor at the University of Washington School of Dentistry, where she's the research implementation manager for the school's Dental Research Center. Marilyn has nearly 30 years of experience conducting clinical trials and clinical practice. She's the associate director of the master's degree program in oral health sciences for dental hygienists and the dental hygiene co-lead for the ECHO-Train grant, training pre-licensed dental hygienist students to provide preventive and restorative care for 0 to 5 age children. Dr. Daniel McNeil is an Eberly Distinguished Professor at West Virginia University, where he has faculty appointments at the School of Dentistry, as well as the Eberly College of Arts and Sciences Department of Psychology. He received his PhD in clinical psychology from the University of Alabama after completing a postdoctoral fellowship at the University of Florida. He's the director of the Anxiety, Psychophysiology, and Pain Research Laboratory at West Virginia University, and a licensed psychologist focused on the assessment and treatment of dental fear and phobia. Professor McNeil has had numerous other appointments, grants, and research programs. Dr. Peter Milgrom is Emeritus Professor, Oral Health Sciences and Pediatric Dentistry, University of Washington. And Dr. Milgrom is a founder of Advantage Silver Dental Arrest, which introduced silver diamine fluoride into the United States. He's the co-founder of University of Washington Dental Fears Research Clinic and co-author with Philip Weinstein of Treating Fearful Dental Patients, the clinical handbook. Dr. Milgrom holds academic appointments at Case Western University, University of Michigan, University of Rochester, and University of California, San Francisco. Dr. Milgrom, let me turn the control of the program over to you.
Thank you, Steve. I want to start by speaking on behalf of all of us on the panel tonight to tell you just how pleased we are that you're joining us and how appreciative we are that you see this topic as important. We've put our heads together and tried to come up with some practical and useful guidance that we think you'll be able to employ as you reopen your practices and as you reestablish contact with your patients. If I could have the next slide, please. This is an outline of the program we're going to have tonight, followed, of course, by an opportunity for you to ask questions and for the panel to respond. As you can see, there are 6 parts of our presentation. In the first part, we're going to talk about teamwork, how we're sort of all in this together. Then we're going to move to talking about how to get the patients to come back and about communication. The third part of our program is going to be about responding to reluctance and upset among patients. And then fourth, we're going to talk about working with patients who are fearful, actually in the practice, in the clinic. Finally, there'll be 2 parts. One will be talking about staging treatment, about treatment planning at this time, about what's most important. And then finally, we're going to talk a little bit about patients who are stressed out and who may need some help that goes beyond our capabilities. And again, we'll have the opportunity at the end of the program for your questions, and we look forward to that discussion. So, Dr. McNeil, you're on.
Thank you, Dr. Milgrom. We're living, as we all know, in highly unique times with little predictability and less control over our lives than we are accustomed to. With that great uncertainty comes unpredictability and uncontrollability, and those 2 factors make life a hotbed for anxiety and even downright fear at times, both in our patients and in dental staff. Over the past few weeks, as a matter of public and personal safety, we've done unprecedented things, distancing ourselves from others, staying within the four walls of our homes and working there, wearing masks in Publix, adjusting to furloughs, lost jobs, and vacated opportunities. We've become accustomed to virtual meetings like this CE offering tonight. Dental practices, unfortunately, have had to shutter their doors, and dental patients have postponed all but the most emergent care. But now we're moving into a new phase in response to the pandemic. Businesses are taking the first steps towards reopening, and dental offices and clinics are beginning to open as well and to be fully operational as soon as it is safe to do so. Dental patients have waited, but now need care, and practices will need to catch up with their patients' clinical needs in the months ahead. And in this context of reopening in our society, communication and safe procedures are crucial. Tonight, we're focusing on understanding the very normal and natural fears that our dental patients and the staff who treat them have in regard to resuming dental care. Because these are such unique times, special, even extraordinary communication skills are needed. Let's move to the next slide. And in this unprecedented time, communication and special teamwork is needed. We're going to begin with a focus on the staff. As we see here, what is crucial is prior preparation with staff and open communication, not only to allow various voices, but to encourage them, to affirm them, to welcome them, and to thank staff for hearing about their anxieties, fears, and worries. It's a changed world in the dental office and clinic, and it's going to require a different set of skills from what we've done in the past and what has worked in the past. It's going to require special expertise in this area of communication, both with and for patients, and within and for the dental staff as a team. Involving staff fully as we begin to reopen is critical, and that is to ensure that messages to dental patients, both direct and indirect, are positive, authoritative, and also are comforting. Patients are going to worry about going in public and going to dental offices. One way to start may be to develop a shared goal or goals for the office and clinic. And you see on the slide at the bottom, one possible goal. Our goal is to safely help patients by providing high quality dental care, supporting the livelihood of the staff and the office, clinic, or business. If there's an existing vision or mission statement for a practice or clinic, that might be a starting point. But even if not, to develop a shared set of goals for the staff as we reemerge and reopen our offices. Now I'm going to turn this over to Marilyn Rothen because she is going to talk about particular procedures that can be employed working with staff in implementing this very important teamwork.
Thank you, Dr. McNeil. We are certainly all in this together. We've been anxious to return to work. We love what we do, caring for patients. It's why, of course, we became oral health care providers, and what we do we know is essential. But many of you have already returned to work, and you're doing your best to follow the ADA recommendations, CDC guidelines, state-mandated restrictions, and regulations. At the same time, it's important to recognize that many on the dental team are anxious about working in this new and uncertain environment created by COVID-19. So in this time of rapid change, as Dr. McNeil said, communication is going to be the key to creating an environment where patients and the dental team can become comfortable with the new normal. So as Dr. McNeil suggested, starting with a clearly articulated shared team goal may greatly facilitate that. But I'd like to talk a little bit about team communication, as it's so important to bringing our patients back during this time of fear about the transmission of the virus. Staff rapport plays a very important part in making our patients feel welcome in the practice, as we all know. I mean, who greets the patient when they arrive at the office? Who seats the patient in the dental chair? Who takes the patient back up to the front desk when treatment's completed? Who spends about an hour with a patient one-on-one every 3 to 6 months? So we know it's the staff who are integral to making our patients feel welcome in the practice and having that sense of trust of our providers. So if staff, however, are fearful about their working conditions, this will be communicated to patients, even unintentionally. But whether it's directly or indirectly communicated, patients anxious about the virus transmission in the dental setting, they will have their antenna up. As oral healthcare providers, we've always worked in an arena filled with microbes, but we've known how to address that. We've had our bloodborne pathogen standards, and we've had our standard precautions there to assist us. Now, as we're returning to work, we're told that oral healthcare providers are in one of the highest risk professions out there in regards to transmissible respiratory infections, in particular right now, COVID-19. So it's very important that your staff feel that there are sensible precautions that have been put in place for the safety of everyone on the team and for their patients. So to do this, good communication is key. It's very important that staff feel their concerns have been heard, that they're able to express their worries. There's so many things for us to think about in this new environment. So with that, it can be important to establish a team leader in the office. Now, the business owner or the practice owner very likely during this interim time has spent a lot of hours looking at the ADA regulation or recommendations, CDC guidelines, state regulations, and so forth, and preparing the office for when the time comes for reopening. It's important to share that with staff so staff know about your concern and what you've been doing. At the same time, staff have very likely been home reading up on COVID-19 and reading these same regulations. And that, on the one hand, is making them knowledgeable. On the other hand, is also creating concerns. So when you come together again, it's good to share those concerns, the ideas, and the solutions. It could be that staff take a lead role in this based on bloodborne pathogen standards and standard precautions. Of course, we know that most offices will have an infection control coordinator. So that may be a great role for a hygienist or a dental assistant. They can be part of the solution rather than part of the problem. There's lots to know about, the PPE. That's a major concern of staff, is having adequate PPE for the right procedures. I know in the hospital settings, you have to learn how to put the PPE on, how to don it. You have to learn how to doff it. And they very often use a buddy system where somebody watches the person coming out of the treatment room and then helps them, coach them through removing their PPE so they don't contaminate themselves. So discussing these kind of things can be very important to make staff feel that they are cared about. As a business or practice owner, it's important to ask yourself what kind of questions staff may be asking themselves. Do they feel they've been heard? Does the business owner care about me and my health, that of my family, care about our coworkers and our community? Next slide, please. So it's going to take everyone pulling on the same wagon to get through this as we establish new procedures and protocols and practices. So the goal is to have everybody feel comfortable that the best measures that we know of are in place, that there's that sense of care and concern. So when we know that the team cares about each other, that will be reflected to our patients. And our staff will have more space, more capacity to listen to the patients and help alleviate their concerns. And as a staff member, then how do you communicate to know that you've been heard? So it's important to speak up and to be assertive about expressing our concerns and worries. But at the same time, it's equally important to think about how we do that. Words are important. In an era of fear, it's very easy to have suboptimal communication, and this can come out as frustration and anger. So think about how you're going to approach this. Start with the positive. Doctor, thank you for arranging this meeting before we begin to see patients. Express appreciation for the work that's been going on to maintain the practice during this closure and plan for the new environment. Use I statements as Dr. McNeil recommended. Doctor, I'm concerned about masks and which ones, if we have the ones we need for the various procedures. What's your understanding of the type of mask needed for this procedure or that procedure? I know we're both looking for ways to reduce aerosols. I've been reading about it. I have some ideas. Could we talk about that? And then, of course, who do the patients talk to about their concerns very often? The dental assistant seats the patient, and the patient expresses their concerns about the upcoming treatment, infection control, et cetera, to the assistant. Of course, they're hoping that that assistant will pass that on to the doctor so they don't directly have to speak to that. So it's going to be, again, so important that your staff are comfortable in this situation, that they feel they have had their concerns addressed, and that as hygienists, as assistants, that we can actually go to our dentist, our leader, our business owner, and ask, how can we help? Could we help call patients and let them know that we're back in business, that we welcome them back? The office is going to look different a little bit, and tell them about the differences. So those are some of the communication strategies that we can use as staff. Next slide, please. And then it's important, of course, we talked about meeting beforehand so that everybody can get on the same page and practice the new procedures and get comfortable with them, get comfortable with wearing the new gear. But it's going to be very important to continue to debrief during this time period. Everything is so new. So your huddles in the morning may be a good time for that, or it may be better at the end of the day to find a time. It's probably a very good idea to plan a longer time once a week to use a variation on the roses, buds, and thorns model, where we talk about what went well, and everybody, kudos to everybody for the support that they've provided and the courage that it's taken in many cases to see these patients. Discussing what needs to be tweaked and what things need to be changed. And I think in the long run, we all know that the recommendations are going to be changing on a weekly basis or monthly basis going forward. So we're really in this for a long haul. And in that case, these kind of meetings can help avoid burnout that can come with the stress of being in a situation of constant change. So now I'm going to hand it over to Dr. Weinstein, who's going to talk about the importance of how we communicate with our patients during this reopening period.
In order to be successful, we need to attract and retain a large number of patients. What I'd like to do is to talk to you about how we can facilitate patients returning to care. The key to this will be establishing a trusting relationship, given that they've been away from us for a while and that they've heard all sorts of horrible and real problems in receiving both medical and dental care. I wanted to emphasize that the goal is not just facilitating the patient's return for one visit, but to try to facilitate them reestablishing contact to be a long-term patient. That, I think, is the most important goal that we have. So I'll talk about mailed communications and telephone communications, and then a little while later, I'll talk about no-shows and cancellations as well. Next slide, please. I'll show you a modified letter that the ADA has provided in its toolkit. And what I'd like to do is to talk about some changes, some modifications that would seem to make the letter even more effective. And I believe you can download it as a PDF. One problem that we see is that a welcome back letter is appropriate, but may not serve well as the initial communication. And I'll talk to the points that lead to the modification of the letter, and then I'll show you the modified letter. The letter, first of all, has to seem that it came from your practice, from human beings who are concerned about their staff, their community, and their patients. To do that, I urge you to share experiences that occurred during lockdown. What about the health of your families and friends and communities, finances? What activities did you engage in? How stressful was it for you? And what sort of exemplary activities and efforts could you highlight that staff members were engaged in during the lockdown? Perhaps volunteering, donating, helping others. It's important, again, that we come across as human and make the effort to reach out and touch not only their dental needs, encourage their dental needs, but encourage the human contact that comes with dental treatment. Okay, safety is our main concern when we reopen. I would like to see what we do to further safety to be on a separate sheet. I think it'd be more effective and wouldn't water down what I believe is most important. And that's showing the patients the concern that you genuinely feel for your neighbors, community, patients. We also will stress that you're providing only procedures that are safe and not using any procedures that could spread infection. Also, while I guess we all hope that we wouldn't be overwhelmed with people asking questions and taking up much of our time, it's important that we give the people that we are trying to reestablish contact with the opportunity to contact us, to write to us, or even to call us. These are anxious times. Next slide, please. This is an edited version. I don't know if you can really see everything within the edited version. Why don't we go to the next slide? I think that would be perhaps more effective. I'll read this. We hope this letter finds you and your family. This is my version. And please feel comfortable if you're going to use this to modify it any way you see fit. We hope this letter finds you and your family in good health in this most difficult of times. All of us have been through a lot over the last few months, and all of us are anxious about the welfare of our loved ones in our community. Like your family, our staff has faced many problems during lockdown, and are looking forward to resuming our normal habits and routines. We are concerned about those who have not been fortunate during the pandemic, and staff have, and we urge you to mention donations, volunteering, and whatever activities they were engaged in. While many things have changed, one thing that remains the same: our commitment to your dental health and your safety. The emphasis in our dental practice is now on safety. The steps we are taking are specified on the next page. At this time, we are providing only procedures that are safe and not using procedures that could spread infection. The details of our services are on the next page as well. We will send you additional information about what has changed and how we will protect your health as the details become clearer. We are looking forward to seeing you again and are happy to answer any questions you may have about the steps we are taking to keep you and every patient safe in our practice. To contact us, to make an appointment, or to talk to us about what is involved in your initial return appointment, please call our offices at. Also visit our updated website. Thank you for being our patient. We value you, we value your trust and loyalty and look forward to welcoming you back to our practice. Okay, on the next page we have, I won't read it, the technical information about what we will do and how we will proceed clinically. Next slide. The goal of our communication is to really provide a bridge from the last appointment to now. One communication is great and useful, but multiple communications and updates are even better. Have you noticed your emails? Have you noticed the TV ads? Have you received letters from different businesses trying to maintain contact? This is an established business practice. They want your business. And so they tell you about members of their team and what they've done for their community. They tell you what they're going to do. They also tell you what's on sale. And so that business practice is very, very useful. And I've talked to recently some business people in my community, and they really agree and are excellent. The ads that I'm thinking of really relate to car sales. Subaru is excellent. They tell you what they're doing in the community. They tell you what their individuals in their company are doing. And they really work hard at maintaining that contact. So personal stories of staff members, any kind of public service or donations, staff and their family and friends, and explaining about the change in services that will be provided. Next slide, please. How do you deal with making telephone calls to patients? Who should call? Well, given that patients have been away for at least a few months, probably even longer, the person making the call should be the person delegated by the office who knows the patient best, who feels most comfortable with making that telephone call, who can call the patient by his or her first name. I'm including a message to you not only about what to say, but what not to say. It's very natural for us when people appear anxious, either verbally or by their behaviors, to say, oh, don't worry about that, it's going to be okay. Paradoxically, that's very ineffective because it indicates to the person that you're not in touch with their feelings. So don't reassure someone prematurely. The strategy, if you are aware that someone is anxious, is to encourage them to tell you more about their anxiety, to let them get it out. That is truly reassuring. That person cares for me. That person is interested in me. That person will take good care of me. We also believe that there should be a script for telephone contact. And we should create a script and go over it, and the staff should agree what we should be saying. We shouldn't be winging it, because the telephone communication that you're making is critical. And if we forget important things, or if we say something that alienates somebody, there's no way that we can come back from that. So, a few suggestions for part of a telephone script. Hello, this is, and we're calling from, and then an initial attempt at communicating. How are we doing in this most difficult of times? Notice this is an open-ended question. You want the person you're talking to talk. An alternative, all of us face problems during this difficult time. What problems have you faced? Again, the goal is to get the person to talk. Not only do you want someone to talk using these open-ended questions, but you want to paraphrase what they told you. It seems to me you're telling me that you're doing okay. You are worried, especially about your grandmother, but you seem to be taking many steps to be safe. Okay, so I urge you to use these open-ended questions and to script them, to come up with questions that you can choose from. Not everyone's going to use the same question, but have a number of these questions that the person making the telephone call will be comfortable in using to establish contact and communication with the patient. Next slide, please. Okay. Dealing with no-shows and cancellations are incredibly difficult, even in the best of times. I want to talk to you about sort of how to interpret and respond to these problematic patient behaviors. First of all, I want to encourage you to think about the goal. The goal is to build and maintain rapport and trust so that the patient will return. And return not just once, but return long-term to your practice. The obstacles to attending can be numerous. There can be everything from fear and anxiety to financial problems to logistics problems. I want to talk a bit about the difference between no-shows and cancellations as I see it. Someone that doesn't show, that makes an appointment, that no-show behavior may be a symptom of fear and definitely of a lack of trust with the profession. And when someone no-shows, they create a barrier that decreases the probability that they'll make a subsequent appointment, because obviously they will be embarrassed. it places both the patient and the provider in a difficult situation. A patient who cancels is someone who trusts the profession and is comfortable with telling them how they feel and what the problems are. That's a good sign and not a bad sign. And even if they can't call to cancel at the last minute, they shouldn't be penalized. They should. Let's talk about reminders. Reminders, usually telephone reminders, sort of fit the model we talked about a little bit earlier. The person who does the reminding should be the person that knows the patient best. And it may not be the receptionist. Remember, these are exceptional times. We want to do everything we can to have the patient come back. And the reminders needn't be only during business hours. The reminders could be in the evening. The telephone call we make to remind patients should be considered more than a reminder. It should be considered a vital communication with a patient. And please, don't punish the patient even if they don't show. All that'll do would be make it more difficult to get that patient to return. There are no easy answers for how to deal with attendance issues, not only in dentistry, but in all of medicine and health services. What should we say when we do contact them, when someone calls to cancel? Should we twist their arm? Should we tell them how important it is for their health? Should we stress how totally safe it is in our environment? Well, I think we should tell them that we understand their discomfort and talk to them about perhaps some alternatives. Perhaps we can have, like we're having now, a video communication session. What are the alternatives to visits right now? What are some timelines? Could we do some treatment planning over the phone? What can we do to communicate with that patient, to maintain our contact, and to keep them in the fold? What can we do? What should we not do to alienate these folks at a time when they're already anxious? One false step and we've lost the patient. So please take care in your communication.
Okay, thank you, Dr. Weinstein. We're going to now turn the program back over to Ms. Rothen, and she's going to talk a little bit about people getting upset and being reluctant.
Thank you. So next slide, please. So in this era of a pandemic, clearly, we're going to have patients who demonstrate both reluctance and upset. This may be on the phone when we try to contact them, and clearly when they come in the office. They may come in, and yet when we see them, they're going to be concerned and reluctant to proceed. So what do we do? As Dr. Weinstein said, reassurance to patients that everything's okay backfires because it essentially denies their feelings, their concerns, and their worries. So what we can do is we can ask them to share with us what they are concerned about. It's helpful to say, you know, others have been concerned. That's normal in this time. So to let them know just that their reaction is a normal reaction. And then to tell them that we appreciate them sharing with us what they are concerned about. Only then can we begin to address it. So we want to demonstrate active listening and saying to patients that, you know, I think you're telling me that you're concerned about this aspect. Did I get that right? Or it seems to me that you really want to continue treatment, but you're concerned about bringing the virus home to your family, to your kids, to your mother. So we can listen to them, hear what their concerns are, demonstrate that we've heard them, and then we can share with them, but by asking them, would you be interested in learning the steps that we will take? So to ask them for their interest. And this really brings us to what's termed the shared decision-making model. So shared decision-making about care has been used in medicine for a number of years and is really coming to dentistry more recently. However, many of you are probably using that and you may not even be aware of it, but shared decision-making essentially is where the patient brings the questions and the values, as here their concerns, and the provider brings the information and the options. So we offer them the information, and then very importantly, and this time period is for fearful patients, is to be able to offer options for care. And Dr. McNeil is going to talk about working with fearful patients, and then Dr. Milgrom will share how we can offer options to our patients, particularly those who do demonstrate reluctance and upset about returning to care or receiving care in our practices. Dr. McNeil?
Thank you, Marilyn. All of us on this panel have worked extensively with highly fearful adult and child dental patients. There's numerous aspects of dental care that evoke fear, including needles and injections, drills and drilling, feeling closed in, and social concerns about interacting with dentists and hygienists as authority figures, worrying about their criticism of one's oral hygiene habits. Over the years, our patients have been concerned with various infectious diseases. Now there's a COVID-19 pandemic, a virus that we do not understand well at all. That uncertainty heightens existing fears and also evokes new ones. And as you see in the slide here, the COVID-19 concerns are normal reactions to a very abnormal situation. It's to be expected, and certainly all of us in our darkest moments over past weeks have probably gone there to be quite concerned about the health implications, but also the economic and life implications of this virus. And in the context of dentistry, this new fear can be on top of existing dental fears and anxieties. And the group here tonight, I'm sure, is well aware that many of the patients with whom we work have, almost half of them have at least moderate dental fear, and 5 to 10% of them avoid needed care in dentistry because of fear and anxiety. And you look at the combinations of those, and it's really quite a tricky situation. In terms of dental fear and anxiety, we know there's various components with dental injection fears and fears about pain, but some of the research that's been done has identified that distrust of dental personnel is a particular subtype, that there are individuals who are a bit suspicious, worrying that are they really sanitizing these instruments. You know, you can see how that could really be accentuated by the current COVID-19 crisis. And then there's also another subtype of medical and catastrophe fears. You know, where something's really going to go wrong. What if her glove rips? You know, what if she sneezes? What if the drill creates an aerosol that's going to have a problem when I walk into the dental office? So you can see how these subtypes of fear can really be accentuated in the current environment. And what I suggest here is that dental fears and COVID-19 fears are likely to combine to at least be additive, but perhaps synergistic. It may be that in this case, 1 + 1 is more than 2, that the whole is more than the sum of the parts. And let's go to the next slide. There's a graphic here that I think illustrates this. And we've talked about the various kinds of, if you see at the bottom of this mountain, the various kinds of economic and social stresses that many of us are under, with change situations socially in terms of work, worrying about economics. And so that's a base level that we all are dealing with, and that probably has grown quite a bit. And the data surveys with anxiety in the population as a whole certainly support this. With the COVID-19 crisis, anxiety generally in society has gone up. And then in the context in which we operate, dental anxiety and fear is on top of that. And it's again, additive and perhaps then becomes synergistic with COVID-19 distress. And if you see on the slide, the dashed line, that's a hypothetical idea at which point avoidance of dental care would take place. And that's part of the worry that we have, is this combination of fears is going to be quite troubling for dental patients. And as Dr. Weinstein was discussing, very difficult for them to resume dental attendance. And I think his point about multiple communications is very important. When we're anxious, tense, worried, our thinking is not as clear and we don't remember as well. And that really argues for this idea of multiple communications. And let's move on to the next slide. And we're talking here about some specific concerns about contracting the virus from staff or other patients. In dentistry, it's, providers work very closely in the personal intimacy zone of the patient. And so that close proximity can be very concerning in the course of this virus. There's been all sorts of news reports about shortages of PPE, and patients may well wonder, has the staff gotten the supplies they need? Are they disinfecting well? And as Ms. Rothen suggested, there's worries in our patients about transmitting it to loved ones, and particularly vulnerable groups, older adult parents, for example. So what can we do here is as Dr. Weinstein was suggesting, is communication. And I propose here that listening may be the most elegant form of communication. It's absolutely crucial in this crisis that simple reassurance won't work, but active listening is so important. We know that in this COVID crisis, there's going to be a increase in generalized anxiety with worry as a hallmark symptom. There may be sleep problems. And one of the things that the crisis, I think, is particularly make us vulnerable to are obsessions and compulsions, obsessive compulsive disorder type of problems, that our obsessions are thoughts, our worries about things, and then compulsive behaviors. And some of that is actually now prescribed frequent hand washing and using hand sanitizers. And so that can get to be very confusing for patients who already suffer with these sorts of issues. Let's move on to the next slide. And this figure suggests a tipping point. And as we move through the pandemic, as practices reopen and become reoperational, it may be that COVID-19 has been a tipping point, or an excuse, a socially acceptable excuse for highly fearful patients to delay further treatment and to become avoidant. And as we have been suggesting here, it's important for dental staff to reach out to these patients in multiple ways and multiple formats. More than trying just to alleviate fears, we may need to do a gradual return, a stepwise sort of return. I think that our patients will be out of practice in coping with their fears, and they may be embarrassed about their absence, and also particularly worried if they've let their oral hygiene slip. And so as we think about moving with these patients back into the initial care and then resuming regular preventive care, I'm going to turn it over to Dr. Milgrom to talk about staging of treatment. Dr. Milgrom?
Thank you, Dr. McNeil. You've laid the groundwork fantastically, all of you. What I want to talk about is again, to reinforce, as everyone has been saying tonight, that we're in the long game here. We're not in the short game. And that what we're really thinking about is what kind of options can we provide for patients so that they have a road to come back, even if they're reluctant. So next slide, please. I think all of us are worried that, you know, the practices are losing income. Staff have been on layoff. Many have been on unemployment. Everybody's worried about the financial viability of the practice. Those ADA surveys that have been done suggested that if this went on till August at the rate that we were at just a little bit ago, that 40% of dental practices would go broke. So this is real. So the first part of this is this is a time to do careful exams. This is a time to demonstrate to patients that you're on top of their oral health, and to take a little extra time and be thorough, okay? It's an opportunity to build trust, to be able to show the patients that you really are paying attention to their oral health. But don't add to their stress with long lists of treatments. Okay, think in stages. Think about what we can do now and what we may want to do when things get better, when finances are better, when childcare is more available, when, you know, our insurance is back. I mean, all of those kinds of things need to be taken into consideration when we start examining patients. And I think, you know, many of us feel uncomfortable if we don't tell the patient everything. And I think this is an example of a place where you need to make priorities. You can say, okay, for right now in stage 1, at this point in time, when we're all worried about how things are, these are the kinds of things that we should do to have you be healthy and maintain your stability. And in the future, we'll talk about more of details about things that we may need to do that we've put off for a little while. But right now, what I want to do is focus on you staying healthy and not having any disease progression. So there are some things we can do. One is that we can dispense high concentration fluoride toothpaste or gel. Okay, we know that works, but it's important that you dispense it. That is, that you have it in your office and that you give it to the patients, as opposed to sending them to the pharmacy. If you send them to the pharmacy, they may not go. They're afraid that they're going to be standing in line with a bunch of people who are sick. Okay, and more importantly, many pharmacies do not even have these products. And so they'll be running around town trying to find a pharmacy that does have them. And that's not going to be good. So get them in your office, even if you don't do that now, and dispense them. And the priority should be high concentration fluoride toothpaste or gel. The second thing is that we want to make sure that we stop the disease progression in its tracks. You know, most of us have gained a little weight during this time of being locked up at home. We've given ourselves permission to eat a few things that we maybe normally don't eat. I certainly am in that situation, okay? And so maybe for those patients that are really concerned about caries progression, or where you're concerned, this is a time for silver-diamine fluoride. This is an opportunity to arrest sensitivity, just to eliminate sensitivity, because that makes people worry. Something's bothering me. I don't know how to interpret it. I haven't had anybody look at it. And we know that silver-diamine fluoride arrests caries lesions. Now, it may turn a tooth dark. You may see some discoloration, but so what? This is only a temporary thing we're doing to try to make sure that people are stable until we get to the next stage of treatment. But the key thing is that we can do these things. They don't hurt. They don't usually require needles and drills, and people will come back because our goal again is building long-term trust. And then similarly, this is a time to use treatments like glass ionomer or cement. We can reduce plaque traps. We can cover open lesions that may be sensitive. Again, this is a method for arresting tooth decay. And again, think of it as an interim step so that that patient goes away with the idea that you were careful, that you looked at their problems, you didn't ignore them. You didn't tell them, geez, it's too bad, I can't deal with this now, but the state won't let me do this. I mean, don't say things like that because that's not helpful, okay? Make them feel like they're part of this process of going forward, and that then they will come back, because there's nothing more important than they return to the practice as we are able to provide these services. Let's go on now and have Dr. McNeil talk about our last topic.
Thanks, Dr. Milgrom. Let's move to the next slide. That's fine. And we care for our patients in various ways. We certainly take care of their oral health needs, but we're focused on the entire patient. And we know that this is an extremely stressful and challenging time for our patients and for our staff. And what we want to do here is provide you with various resources, and then there's also a handout and possibly something you can print out as a wallet card that I think may be helpful to you. Listening and reflecting, we've talked about that tonight. Don't try to fix it, or particularly to suggest that everybody's having a difficult time, but to listen and listen actively as we have suggested tonight. Sometimes clinicians worry that if they ask patients who seem very distressed about any thoughts or intentions about self-harm, that would actually prompt them to do it. And the evidence is much to the contrary. We know that individuals who have made a suicide attempt typically have mentioned it to someone in their life prior to that happening. And the point there is, how do we respond to that, and what resources do we have if we believe that there's a threat to self-harm, or if there is a comorbid mental health condition, depression or anxiety, or if the person is having a particularly difficult time in reaction to the COVID crisis for social reasons, family reasons, employment reasons. And so not only to actively listen, but also at times it's important for us to share some information to get further help for our patients. Sometimes we have the fortunate circumstance of having a relationship with a mental health professional that a referral can be made directly to. Sometimes that's not the case, and sometimes dental practices are concerned about that scope of practice. And so this gives you I think a route to consider. And my suggestion to dentists and hygienists and assistants with patients who seem particularly distressed, that you're concerned about, is to simply say something such as, may I give you some resource information? Perhaps you or someone you know would find it helpful either now or in the future. And so it's a soft way of providing that. Sometimes people worry about offending patients, but I think that kind of route of sharing with them allows it's a caring gesture. And let's move on to the next slide. There are a couple of opportunities with this National Suicide Prevention Lifeline. There's a telephone, a talk, there's counseling that is available, but there's also, if you can see in the bottom green there, there's a chat line. It's not text, but it is a chat web line. Some, I think, particularly younger generation may prefer that sort of way. You can use either. And this wallet card that you see, the green National Suicide Prevention Lifeline wallet card, something you can download. could print off and then make available to patients. I would suggest, however, to in having those available, that they not be left out, and they be stored in some way so that they are sanitary, and that patients in receiving them will know that they're sanitary. That can get to be very important. Let's move on to the next slide. There's even more resources available. The helpline from SAMHSA is an information and referral line, good across the USA. It is not counseling, it is confidential, it is free, but it can help link patients to available resources in your community. And then we're going to go on to the next slide. There's even a particular source here for veterans, individuals from the service, National Guard, Reserve, but also even their family members and friends. So I think you can see there are a variety of resources available. I just want to return to that very kind of soft way of potentially presenting some of these resources to patients is, may I give you some resource information? Maybe you or somebody that you know would find this helpful, either now or sometime in the future. And I think that's an expression of concern and caring for the entire patient. And with that, I'm going to turn it back to you, Dr. Milgrom.
Thank you all for this fantastic discussion tonight. I think it's now time for some questions and discussion. So Steve, you can take it from here.
Absolutely, yes. Thank you all for a very good discussion, some very interesting and pertinent points. We have several different questions here. I'm going to try to consolidate them into a few, and I'll throw them back out, and whoever is most appropriate to answer, please feel free to do so. For starters, it's kind of a reverse of what we were talking about. A couple of questions focused around patients that are dismissive of extra precautions that we're taking. For example, patients that may come in or be angered by the situation that they need to wear masks. Do you have any advice to overcome those types of issues with patients?
Phil, would you like to take that?
Yeah, I think I would take the same approach that I would take with people that have fears. I would say, I want to understand why you're concerned about masks. Could you tell me? I did have a conversation coming out of actually going into Home Depot, when you have to keep 6 feet away, but the staff at Home Depot wasn't wearing masks, but the people going into Home Depot, kind of every other person or so is wearing a mask. So I had to wait to get some propane. I was standing next to the woman who works for Home Depot that wasn't wearing a mask. And I asked her diplomatically, kind of, could you tell me a little bit about how come you guys aren't wearing masks? And she said to me, if I put a mask on, I gag. It makes it difficult for me to breathe. She also said she had COPD, which is, I didn't go there. I didn't talk to her about any kind of other safety issues. It wasn't the place, and I knew it's very difficult to influence someone's beliefs in a chance encounter. All they'll do is become rigid. So I think get the person to talk, because if you can't get the person to talk, you can't influence them. If you can get them to talk, you can have some airtime. You say, well, thank you for telling me about how you feel. I think that's really interesting. Would you give me the opportunity to tell you why I think it might be important? Not that I'm going to change your mind, which is really what the goal is anyway, but they'll give you some airtime, and hopefully maybe they'll actually hear you.
Yeah, very good. Appreciate that. The next question came in Can the panel draw any comparisons, correlations, or outlooks from the HIV fears and changes that impacted dentistry in the 1980s and 1990s?
That's a great question. I think, you know, I have to tell you that I was a dental student in San Francisco when that all started, you know, right next to the Haight-Ashbury, right next to the center of the beginning of all those infections. And we reacted in fear. We rejected patients. We told them we wouldn't see them. If we did see them, we dressed up in spacesuits and pretended that they were lepers. We did a lot of damage. Our ignorance did a lot of damage. So I think what we've learned from that is that we want to be knowledgeable, but that our real goal here is building trust. And what we failed to do at the beginning of the AIDS epidemic was to build trust. And it took a huge amount of effort to eventually get to the point where we were knowledgeable and comfortable enough to recognize the nature of the problem we were facing. And then we approached it as a professional group. I see Marilyn shaking her head like she was there too.
Yep, definitely there in that time frame. I worked in the University of Washington Hospital Dental Clinic at that time period. And so that was very interesting. You know, you had hemophiliac patients come in and you knew they were going to be HIV positive because of the blood transfusions and things you had been through. But interestingly, I think one of the things about that is that many patients sought care there, even though they didn't have medical concerns, because they thought that all the infection control procedures and protocols would be in place in a hospital. So patients were afraid of contracting the disease when they came in to get their dental care.
That makes really good sense to me. I had a friend have her son die. A young boy died who got a blood transfusion during that time, and it makes perfect sense what you're saying.
Mm-hmm.
It's an opportunity for building trust.
As we were preparing for this seminar, Marilyn and I actually had a very nice conversation about the parallels in remembering points in our career. And, you know, just as you were saying, Dr. Milgrom, I think the uncertainty that existed at the start of the HIV/AIDS crisis was really quite problematic. We didn't know. And similarly, there's things we don't know about COVID-19, and I think that's heightening anxiety on the part of staff. Patients are worried about contracting this by coming into the office. And so I think that, you know, maybe the hope is, as you look at certainly HIV and AIDS is certainly still a problem, but we understand more, we're better able to manage, we do better prevention. So hopefully, you know, we're going to be in that same route with COVID.
My memory, we were one of the only clinics that treated HIV patients. And there was a lot of fear because this was new stuff. And as time went by, more and more practices were getting kind of comfortable. There was actual training that was occurring at the dental school about how to deal with this problem. It's just another infection control issue, okay? And so through, I guess, the passage of time and with additional instruction and realization that no, the dentists that are providing services to those folks aren't getting ill. There was much more comfort over time. And I think time's going to cure this problem more than anything else. Time and what we learn from now to then about how to provide care and how safe we actually are or are not.
That's a great question.
And, you know, just another quick follow-up on that. I think one of the things, you know, early on, we really identified certain patients that we thought were likely to have HIV or AIDS. and then gradually develop this realization it can be anybody, it can. And I think that's the same way with COVID. We have to realize even individuals who are asymptomatic can have it, can be carriers. We've got to be careful with everyone and treat all of our patients fairly and equally.
Excellent. Thank you very much for that. Several questions have revolved around the ADA letter and the welcome back letter and how that takes place. So I'll try and paraphrase the question here. Are you suggesting that one letter should be prepared and used for all patients, or should it be a series of communications starting with a more personal touch, how you're doing, how we are doing, followed by the details of how the experience will be different at the office?
My response to that question is an unqualified yes, that multiple communications initially that are personal in nature. I think when the practices get together to rebuild their teams, they should talk about their experiences and the experiences of their relatives and friends and neighbors. And that's grist for the communication mill to share with patients. And we should be providing information, but that's not, if all we do is provide information about safety, I think that will miss the mark. And I think multiple communications are always better than one communication. Can anyone add to that? I don't know if I'm hitting the mark on responding.
I think you're exactly right, Phil. I think we often think about patients that are going to have worries that we're not properly prepared, and that we're more concerned about ourselves and our business than we are about them. And so every opportunity that we can take to build trust and build and through that build knowledge of the steps that we're taking, and that we're real human beings that are just as concerned as they are about these things, that's just going to make it a lot easier. It's not a panacea. I mean, that's obvious, and that's why I talked about the fact that we need to offer some treatment alternatives. And Dr. McNeil talked about a slow start. That sometimes these patients may be out of practice. Their fears may be welling up, and so maybe we need to start with them as if they were a beginning fear patient, and that we need to do some small steps to bring them back into the practice so that they can gain confidence and they can master their fear and be able to continue as a patient. The worst possible thing is to scare them away.
That isn't to say that some patients are rip-roaring ready and open to the most complicated, expensive care you could ever provide. Some will be, but play it as it lies. If you sense that this person needs some warm-up and needs to have shorter appointments with less ambitious goals, then that's what steps need to be taken.
Okay, very good. Thank you for the answer. I'm going to continue with that question in a slightly different direction. In reaching out to patients and trying to schedule appointments as they come back to practice for things that may be overdue now, is there a point, and do you have any information on what that point is too much, where the office may appear desperate?
Who would like to take that?
I think you're a good person for that, Dr. Milgrom.
Is there? Yeah, I mean, so one kind of thing is there too much information? Is that the gist of the question?
Is there too frequent of a communication that keeps information going out to that patient? How are you? We're doing.
I don't think so. Go ahead, Dan.
I think Dr. Weinstein said something about this, is, for the staff member who best knows the patient to reach out to them. And I think if you sense a reluctance, I think we should individualize it, and not do the same exact thing with every reluctant patient. There may be some we need to give extra time, and it could be misperceived that we're hounding them or that we're desperate to get patients in the door. And so I think that individual approach. Other patients are just busy and they need those reminders and probably appreciate those frequent reminders. So I would say really make it individualized.
Right. In fact, I'd go on to say, it's perfectly reasonable to ask somebody, are you the kind of person that likes to be reminded? I'm certainly not, and I don't like it when people call me up and remind me, because when I make an appointment, I put it on my calendar, okay? And I don't miss appointments, but other people have very complicated lives and childcare problems and unreliable cars and all that other stuff. And as Dr. McNeil pointed out, this is a mountain. And what we've done is we've piled all this other stuff on top of normal stresses and strains. And these are really accentuated now. So I think there's probably not too much for some people, but as everybody's saying, let's individualize it.
Okay, excellent answer. Thank you very much. So same general topic about communication with patients. You discussed shared decision-making with patients. Do you feel that there should be a portion or a majority of that or all of that that takes place over the phone prior to the visit to understand goals and fears in order to limit the chair time, or does that take place in the chair? And if so, is it a sit up and wear a mask during those types of conversations?
That's an excellent question.
Yeah, one of the things that we talked about, and those of you who were able to participate in some of the other webinars, there's a lot of discussion about the use of telemedicine, and many dentists are now using modern technology. We all have it in our telephones and in our iPads and other devices, so that we can talk to patients at home. And I think it was Dr. Weinstein suggested maybe it goes on in the evening, or it goes on at a time that isn't occupied with other kinds of treatment or disruptive. But if a patient needs that, or a patient feels reluctant to come in, then this is a great opportunity for us to engage in new technology. For those of us who are a little bit over 40, some of this stuff is new, like using these webinar devices. The speakers had to rehearse because they're not so good at using all these technologies, and they didn't have their grandchildren available to show them how to use them. So same thing for our communication. Marilyn, did you want to add some more?
Oh, well, I was just going to say what you said essentially about teledentistry. I think that it's a great thing to ask the patient. If the patient is reluctant to come in, we're all getting used to this, and I think that you can have very meaningful conversations via, Zoom or GoToMeeting or whatever platform you use to have that conversation with patients. We're used to doing it in person, so it's a big change for us. But I think now a number of our patients will find have actually experienced these kind of, telemedicine appointments. Somebody I was, teaching a course today, and the instructor was late because she had to do a Zoom meeting for her daughter, medical appointment with her daughter. So I think, patients are becoming very accustomed to it, so we can use it readily.
You bet. Phil, do you want to add something?
Yeah, I had a very positive appointment with one of my doctors, and I think it's a wonderful technology, and it may have a lot of utility in dentistry, especially during this time. I think it should be an option. We can communicate. We can ask our patients, how comfortable would you be if we talk to you on the phone about what we're doing, what we're planning for you as an initial step, and let them respond, either yay or nay.
That's great. Dan, you want to add something?
Yeah, I just wanted to return to this theme of trust that was brought up earlier. I think it's really important that it's occurred to me in our discussion here that for the highly phobic patient, that teledentistry session may actually be very helpful in allowing them to start to get accustomed to interacting with the dentist or the hygienist in preparing for care, because you know that no instruments are going to be used while we're doing teledentistry. You know, you've got that buffer, and I actually think that would allow a bit of exposure, as we psychologists call this, exposure, and gradually getting accustomed. So maybe there's a new approach there. I'll say to my fellow panelists for dental phobia.
And we can approach them without all our hazmat gear on, you know, so in some ways it's actually very personal.
Yep.
Oh, that is excellent point, Marilyn. Yeah, because that all the gear is another factor that could be a bit scary.
Pretty soon, we're going to need an intraoral app on our phones.
Right.
Well, those
Not
things
only
are
take a
starting to
selfie,
develop.
but you can
Yeah.
look in their mouths.
Okay, Steve, do you have another question?
Yes, indeed. Thank you very much for that. The next question revolves around staff. There are actually a couple of questions I'll try and combine into one. If you involve staff and give them say-so in opening and procedures and basically anything from timing of opening the clinic back up to how patients are cared for, and there's disagreements and things that they're not willing to do, even though it may be above and beyond what the OSHA requirements are, or things that perhaps PPEs that are just simply not available. Do you have any examples or concepts that can help overcome those issues?
So I think that's a definite challenge, you know, for offices. I mean, I certainly, you know, recognize that. The theme of building trust with patients, I think if we don't build trust with our staff and among our staff and are comfortable as a team, that we feel we can rely on each other and count on each other, then we won't build trust as easily and readily with patients and be able to have a productive practice. So you're describing a situation where, you know, we do have a PPE shortage. That can be a problem. So are there, you know, creative ways that we can address that? Are there procedures we can do with the type of PPE we have and reserve later on for, you know, say procedures that are aerosolizing and that we need, you know, the N95 masks for when those become available? Just like we've put off now and limited our practices only to emergency care. So I think that it's, you know, again, very important to, you know, as you have that discussion with the staff, to make sure you understand their concerns and, you know, that they're well aware transparently of what is available, what we know, and, you know, what is the goal we want to accomplish together in the practice. It's, you know, so that they feel that they have been heard. This is maybe not unlike the HIV era, where, you know, we didn't all have gloves yet, and we didn't have good gloves to use as we started back up in that process. So, you know, maybe we have to adapt a little bit to, you know, a little give and take with the practices. Others have perspective from your standpoint?
I think one of the things that I would say is that it would definitely take some time, that there will be differences of opinion, different levels of comfort. And I think that the time to talk about that is not the half hour before the first patients cross the threshold. It's the day before or the week before, so you don't want that extra pressure of having to reach some decision in a short period of time. And I think, you know, use the group process and the staff to, you know, talk about the various concerns and how they might be dealt with.
Dan, I think your point is really well taken, and you know, this goes back to something we said before. I think Marilyn has talked about a lot, and that is work out who's going to be in charge of infection control. Work out, have scripts and practice taking gear off and because many of the staff members who may be reluctant may need a concrete demonstration that the steps that are being taken are appropriate. And as I think everybody's saying, you don't want to be doing this in front of patients. You don't want to be doing this at the last minute. it takes some more thought. And you know, I think that the active listening skills that everyone's talked about, Phil particularly talked about, are important here, to give that staff member some airtime, to give that person an opportunity to express their concerns and to be heard, and to be, you know, and to paraphrase, do I really understand this right? You know, what kinds of things can we do together to try to solve this problem? Because otherwise we're going to have a confrontation, and that's going to be, the patients are going to pick that up in a minute, and that's going to be practice destroying, not practice building. Steve.
Okay, thank you very much for that in-depth answer there. I think we've got about 2 more questions that I wanted to ask. The next question is, for fearful patients that simply don't want to come in for a visit and teledentistry is the only option for them, what are some suggestions for home care or home procedures that can be done, or things that you can do to keep them in good health until they are able and willing to come back to the practice?
Okay, I'm going to take that one, at least to start. You know, going back to this idea of we want people to be healthy and we want them to be stable. We recognize that they may be reluctant right now. Okay, so number 1, obviously, are fluorides. You know, certainly encouraging toothbrushing with fluoridated toothpaste and the use of high concentration fluoride gels or toothpaste are absolutely appropriate at this point in time, along with, you know, the simple things like using toothpicks and other kinds of you know, interdental cleaners that we have available to us. That's going to help keep people comfortable. The second part of this is there are things like you can mail that fluoride to the patient. You don't have to write a prescription. Again, you can offer to mail it to them, because that's going to be extremely reassuring that you're not trying to cajole them into coming in, but instead you're saying, well, I really hear your concerns. So how about if we take some steps together that will help solve this problem? The other thing that patients can do with a little bit of telemedicine, teledentistry, would be to use some topical iodine. If they have open carious lesions, they can get betadine or the equivalent in a pharmacy, and they need some instruction. But they, for example, if they have an area that's very sensitive or an open cavity, they can put that iodine on that, say once a week for 3 or 4 weeks, and then maybe once a month, until such time as they're able to come in, and that's going to put that cavity into a holding action. And you know, similarly, we can use telemedicine for abscesses and for, you know, symptomatic things. If they're afraid to come in, it may be that we're going to prescribe antibiotics, or we're going to prescribe warm rinses, or any other sort of approach like that, that again gains their confidence, allows them to have their decision not to come in to be respected at this time.
I think via webcams is you actually can see quite well if, you know, patients get up close, and your you know, staff can actually do a follow-up with them or help them with their home care. You know, whether they're having trouble using a bridge threader or proxy brushes in areas, or toothbrushing. So, you know, I think the technology, I've had lots of hygienists tell me that they're actually already using this with patients, and it's working very well.
You know, you made another point, Marilyn, I think it's really important, and that is, let this not be a one-time contact. Okay, if you suggest to somebody that they use those fluorides, or that they use iodine or anything else, that you should then call them back up after a certain, you know, allow them some time, and call them back up and problem solve. How's it going? You know, are the symptoms resolving? You know, is there anything I can do to try to be more helpful? Because again, I mean, I think our psychologist colleagues have made it very clear, multiple communications are going to pay off.
Okay, excellent. Thank you very much for that. And then the last question is revolving around liability. There are patients that will refuse appointments and they may not come into the practice, and there might be progression of disease while they're out of the practice. Is there concern of the liability, and how do you suppose that we document their refusal to come in so that it doesn't appear as neglect?
let's start by making it clear that we buy malpractice insurance to protect ourselves against things that we can't otherwise control. And this is a time to make sure that your malpractice insurance is up to date. But more than that, if you take the steps that I was suggesting, that is, try to use the teledentistry approach, try to to find strategies that will both keep people healthy and stabilize existing problems, and to document that you've done that. Nobody's going to question your behavior. And the worst possible thing right now is to try to cajole people, because if they have fears and they are concerned, you trying to stampede them into coming into the office by making the consequences of their behavior sound so dire. If you don't take care of this right now, something terrible is going to happen. Well, they already think something terrible is happening. So you're not solving the problem by doing that. And if anything, you're breaking off the relationship. You're causing distrust, because people begin to wonder what your motive is. So I think maybe Phil or Dan would like to comment on that.
I would comment on that only to say that I think one way is to start to find out from the patient, if they will, why they won't, come in, what they're afraid of. Not that you're going to change their mind, but just to respect them and understand. And then it's the perfect time, I think what you were saying, Dr. Milgrom, is this is really the shared decision-making model, where the patient has their questions and their values, and they make some decisions. And then you've shared with them the options and the information.
Right, Phil?
Yeah, there's a very large literature, some of which is probably 70 years old, that says that increasing patients' fear, okay, by telling them things like, some disease is going to get you, or you have to do something right now, doesn't work. And in fact, it leads people away from the behavior that you want them to engage in. It just doesn't work. And so don't do it. There's also a literature that says that punishing people results in people staying away from the punisher, and that sort of smacks of common sense even.
Yeah. I want to ask the group. We don't have much time left here, but I want to ask the group a question. This might seem like an oddball question, but it's. I have a family event coming up, and I don't like the way my tooth looks. Doctor, can't you do this? I know you said that you're not supposed to do this right now, but can't you do this? Who'd like to take that? Go ahead, Phil.
I know the answer because we faced these problems multiple times in the past. In the beginning, we did what we knew wouldn't work and would be ineffective. And sure enough, when you do something that goes against what you believe in and what you think is the best way to proceed, it usually comes back to haunt you.
That's exactly right.
And I think I would add, this is another example of getting the patient to talk. And, so what is this family event? Would you tell me about it, and get them to articulate why it's important. And then, thinking about this from a motivational interviewing kind of perspective, hopefully they would say something along the lines, I know you're really not supposed to do this now, but it's really important to me. And then your response can be reflective, but then picking up on that. I really appreciate your saying that that this is a procedure that we really can't do right now for your safety and the safety of the staff and the other patients. And that's kind of that motivational interviewing, kind of trying to grab that little bit of change talk from what the patient has said.
Right. And a rational person is going to respond positively to that kind of approach. Steve, let me turn it back over to you.
Excellent. Thank you very much to all the presenters for joining us this evening, and thank you everybody for joining us as well. Keep in mind the handouts are in the handouts on your screen right now. You can download those as I close out here. Remember, your CE certificates will be emailed to you within 2 hours after the end of this presentation, and don't forget to check your spam folder. Follow our social media for updates on new live CE webinars that will be upcoming. The link you see on screen will give you access to all of our archived webinars, including our panel discussion tonight. As soon as we can prep it and get it loaded with the CE quiz, it will be loaded there. Should you need help accessing any of these or any of our other CE courses, please call us at 877-866-9113. On our website, you'll find a button to request an informative staff meeting for you or your office, which can be in person or online. Education on the latest oral health prevention is what we do. We can't wait to get back to what we do best, helping you serve your patients. So thank you, everybody. Have a wonderful night.